Today's topic is intraoperative evaluation of tricuspid valve. Coming to the introduction, tricuspid valve function plays an important role in several clinical states, including left heart diseases and heart failure, and also in the development of functional tricuspid regurgitation. These all things are directly associated with increased morbidity and mortality. The most common etiologies from functional regurgitation results from RV dilatation and dysfunction from left-sided cardiac diseases also, including cardiomyopathy and mitral valve disease. Imaging of the tricuspid valve using transesophageal echocardiography seems more difficult than imaging other cardiac valves due to its complex valvular nature and also anterior, and it is far field from the probe. The focus of the TE during surgery would not vary from preoperative TE, but we have to consider anesthesia-induced changes of ventricular contractility, preload, and vascular resistance when interpreting these images. First, we have to know the anatomy. The tricuspid valve is the largest and most apically placed valve, and orifice is between 7 to 9 square centimeters, and it comprised of 3 leaflets of unequal sizes. These are septal, anterior and posterior leaflets, and along with it you have the tensor apparatus, which is nothing but annulus and chordae tendineae. Among the 3 leaflets, anterior leaflet is the biggest and the longest, and it covers the most area and also have most movement. The posterior leaflet have multiple scallops and is shortest circumferentially, and it may not be clearly separated from the anterior leaflet in approximately 10% of the patients. The septal leaflet is the shortest in the radial direction and the least mobile. It is attached to the tricuspid annulus directly above the interventricular septum. It is inserted into the septum less than 10 mm apically to the septal insertion of the anterior mitral leaflet. That is why it is called as apically displaced. Coaptation will be at the level of annulus or just below it, and the coaptation length is 5 to 10 mm. This has to be remembered because this excess of coaptation length functions as coaptation reserve, allowing some dilatation of the annulus before malcoaptation occurs. The papillary muscles and the chordae tendineae, as we spoke, comprise of this tensor apparatus, and there are 2 distinct papillary muscles, anterior and posterior. The largest muscle is typically the anterior papillary muscle, with chordae tendineae supporting anterior and posterior leaflets. The posterior papillary muscle, which is often bifid or trifid, and lends this support to posterior and septal leaflets. The septal papillary muscle is variable, and sometimes it in up to 20% it may be even absent. And chordae may arise directly from the septum to the anterior and septal leaflets. That's why this is called as septophilic. The septal and anterior leaflets of the tricuspid valve connected to the interventricular septum, and the anterior and posterior leaflets depends on a large anterior papillary muscle along the anterolateral RV wall. Because of the fixed length of the chordae, displacement of either the RV septal or lateral wall position will affect tricuspid coaptation. The normal tricuspid annulus is D-shaped, and it's a non-planar with 2 segments. One is C-shaped larger segment that corresponds to the free wall of the RA and RV, and a shorter relatively straight segment that corresponds to the septal leaflet and the ventricular septum. The tricuspid annulus is a dynamic structure, and it can changes there will be significant area changes up to 30% during the cardiac cycle. Normal tricuspid annular circumference is 12 plus or minus 1 centimeters and 11 plus or minus 1 centimeters in 1 centimeter square centimeters respectively in healthy subjects. Finally, the three important structures lies in the proximity of the tricuspid wall should be remembered. One is non-coronary sinus of Valsalva is next to the commissure between anterior and septal leaflets. The atrioventricular node and the bundle of Hess crosses the septal leaflet attachment 3 to 5 mm posterior to the anteroseptal commissure. The right coronary artery exits the right coronary sinus of Valsalva and courses in the right AV groove posteriorly to the crux of the heart, where it takes an acute bend and continues downwards in the posterior interventricular sulcus. Coming to the echo findings, the primary goal of pre-bypass TE is to evaluate the valvular etiology, the severity of tricuspid regurgitation and the hemodynamic consequences. For etiology and hemodynamic consequences, to evaluate the tricuspid valve leaflet or apparatus morphology should be evaluated, annulus size along with RV dimensions and function, and pulmonary artery systolic pressures should be evaluated. For TR severity, the color Doppler jet area, vena contracta, flow convergence and hepatic vein flow reversal should be evaluated. Based on the comprehensive preoperative TTE examination, pre-bypass TE should quickly double check the TV morphology related to pathological mechanisms with better image quality than TTE. There are 4 standard views we have to remember. One is midesophageal 4-chamber view, midesophageal RV inflow-outflow view, and transgastric RV inflow view, and transgastric tricuspid valve short axis view. Coming to the midesophageal 4-chamber view, here you can see septal and anterior leaflets. Coming to the second one, that is midesophageal right ventricular inflow-outflow view, where you can see septal and posterior leaflets as shown. And third one is midesophageal modified bicaval view, where you can see anterior and posterior leaflets. And the second other one is transgastric 2-chamber view, where you can see anterior and posterior leaflets. And all the 3 leaflets are seen in transgastric right ventricular basal view, as shown here, all the posterior septal and anterior leaflets. In 2D TTE, we measure the tricuspid annulus diameter from the apical 4-chamber view, and a diastolic diameter of more than 40 mm or more than 21 mm per meter square shown as significant annular dilatation. In 2D TE, we measure annular diameter both from midesophageal 4-chamber view and midesophageal RV view or biplane view. And at least 2 different cut planes with or without color Doppler are required to evaluate morphology and regurgitation. Hemodynamically significant chronic regurgitation leads to enlargement of right ventricle and right atrium and IVC, and ultimately deteriorates the RV performance. The interventricular septum has become flattened in diastole due to volume overload, or both diastole and systole with pulmonary hypertension. The RV dilatation is indicated as a linear dimension, more than 42 mm at the base and more than 32 mm at the mid-level, and the RV focused view in 2D TTE, or the relative size of RV, is larger than that of the LV. Multiple parameters have demonstrated the clinical utility of clinical utility using TE, such as fractional area change, TAPC, and motion tissue motion annular displacement and RV strain. Right ventricular fractional area change is measured by tracing the endocardial border of the right ventricle in midesophageal 4-chamber view, where it is calculated using end diastolic area and end systolic area, and the value, if it is less than 35%, it denotes a right ventricular global systolic dysfunction. For evaluation of longitudinal RV systolic function, TAPC is commonly used in M mode, where the cursor should be aligned in the RV free wall as parallel as possible to the movement of tricuspid annulus from the midesophageal 4-chamber view, and if it is less than 17 mm, it is abnormal in TTE. However, TAPC in TEE is challenging to align in the lateral wall. Therefore, several modifications have been used to measure lateral tricuspid annular displacement or even in a speckle tracking imaging algorithm. Global longitudinal peak strain of the RV free wall is also considered a reproducible and feasible index for RV function with the advantages of angle dependency and prognostic value. This is how endocardial border tracing should be done, and also TAPC is being shown here. Coming to pulmonary artery pressures, among the hemodynamic assessments of right ventricle, pulmonary artery systolic pressure estimation using TR velocity is the most commonly performed. PASP can be reliably determined from the peak jet velocity using Bernoulli's equation. That is, we have to multiply peak velocity with 4 and we should add area pressure to it. And according to the 2020 guidelines, TR severity can be graded into progressive, asymptomatic and symptomatic. And we'll see, as shown here, we will see central jet area cover, central jet valve hemodynamics, and it's divided into valve hemodynamics, hemodynamic consequences and clinical symptoms. And we will see central jet area, vena contracta and effective regurgitant orifice area and regurgitant volume. Severe valvular lesions such as fly leaflets with no cooptation or severe annular dilation with marked leaflet tethering in 2D might be enough to show severe TR. For further hemodynamic flow information, qualitative or semi-quantitative imaging of the color flow regurgitant jets, vena contracta with proximal isovelocity surface area diameter and upstream vein flow is recommended. Traditional TR severity quantification with effective regurgitant orifice area or regurgitant volume may not be suitable for in the intraoperative settings. Coming to the color Doppler jets, the color Doppler is primarily used for detection of valvular regurgitation and visualizing the origin and the components of the jet such as jet area, vena contracta and flow convergence. Optimizing the image by adjusting gain and Quist limit is required, and one could expect a slightly larger jet area with TE due to higher transducer frequency. A larger central jet, more than 50% occupying right atrium of any eccentric wall impinging jet would be considered as severe TR. Coming to the vena contracta, the vena contracta is the narrowest portion of the regurgitant flow immediately downstream from the regurgitant orifice. Because of the cross-sectional area of the vena contracta being similar to the EROA, the vena contracta is an important parameter to determine TR severity. Vena contracta width, if it is more than 7 mm, it's considered as severe. And the shape is usually ellipsoid and have additional orthogonal image planes. Coming to the flow convergence, proximal to the regurgitant orifice provides a well-known semi-quantitative parameter PISA. It's simply shifting the baseline of the color scale in the regurgitant direction jet at Nyquist limit of 30 to 40 centimeters per second. And the PISA radius is measured from the point of color Doppler aliasing to the vena contracta, a radius of more than 0.9 centimeters at the baseline Nyquist limit of 28, it shows severe TR. So, coming to the hepatic venous flow systolic reversal, the hepatic venous flow systolic reversal is an additional qualitative parameter suggesting severe TR. Coming to post-cardiopulmonary bypass TE, post-surgical TE surveillance is critical to provide opportunities for fixing leftover lesions or unexpected complications immediately to avoid unnecessary future open heart surgeries, so-called safety net. Given the hemodynamic status They should perform the post-surgical TE during the transition of the CPB, primarily focusing on the tricuspid valve surgical results, following by other basic surveillances including cardiac function and extracardiac fluid collections. We should examine the morphology of prosthetic valve or ring and its functions using TE depending on the surgical procedures. A color Doppler imaging is necessary for detecting any residual leads, and any trans-tricuspid valvular mean pressure gradient less than 5 seems acceptable, but this depends on the heart rate and volume status. After effective communication on site, the surgeon and echocardiologist and anesthesiologist decide upon either a continuous successful weaning process or an unfortunate but necessary additional pump based on the TE information. Thank you.